Morning, everybody. Thank you for joining our presentation. Today I am introducing Dr. Emmanuel Taban. For those people who don't know, he is a founder of this platform. He is originally from South Sudan, and he fled his home as a child and eventually made his way to South Africa, where he became a medical doctor. He specializes in pulmonology and critical care, gaining widespread recognition for pioneering the use of bronchoscopy in treating severe COVID-19 patients. Dr. Taban is also a published author and an inspirational figure in medicine and resilience.
Thank you, Leanne. It seems like you're not really that tired. Today, our topics, we're going to be discussing mediastinal mass. It's something that I was caught out of surprise, and I was told that's my day to present. But I thought maybe you can have overview of the mediastinal mass, which you probably encounter in our daily lives, whether you're in casualty, whether you're a physician, whether you're cardiothoracic, or depending which specialty you are, you'll be confronted with such kind of X-rays. See. Okay. The learning objectives, of course, will be to understanding the anatomy of mediastinum, to identify common mediastinal tumor based on locations, recognize the clinical presentations of the mediastinal tumors, diagnostic evaluation of mediastinal tumors, and formulating management strategies, and recognizing and managing potential complications, implementing multidisciplinary approach to the treatment. So, mediastinum is defined as a space between the lungs. The boundaries of the mediastinum are as the following: thoracic inlet superiorly, diaphragm inferiorly, and sternum anteriorly, followed by spine posteriorly. And if you look at this X-ray, which is a lateral X-ray, you could see the potential space of anterior mediastinum, which is here. That's your anterior mediastinum. And then you look at your middle mediastinum, which is between where the heart and great vessels lie, and then posterior mediastinum underneath. So you could actually see that on the X-rays here. And then you look at the middle, and then anterior mediastinum, which is normally this air space, retrosternal air space. So anterior, of course, which we say for retrosternal space anterior to the heart and great vessels. And middle would be between your anterior and posterior compartment, and posterior will be a posterior heart borders and trachea to the posterior aspect of the vertebral bodies. And this is quite a very nice CT scan looking at the three spaces, which you can also classify as a prevascular, which is again, which if you look at my head, that's your prevascular area. And then you have your visceral compartment, where your heart and great vessels are. And then you have your paravertebra. So mediastinal mass, of course, in adults, 25 to 30% are malignant. High portion of 50% in children. Symptomatics, more likely 50% malignant compared to asymptomatic 10 to 25%. Symptoms are normally related to compression, invasion of adjacent structures, such as airways, blood vessels, where we severe vena cava syndrome that I will discuss later, nerves such as phrenic nerve, recurrent laryngeal nerve, and symptomatic trunk. Of note that it means their clinical presentations might be very atypical because patient might come with Horner syndrome where they're having a meiosis with the constriction of one pupil because of the involvement of the sympathetic trunk ganglions. And also, or they can present with vocal cord paralysis, or they will present with actual left hemidiaphragmatic pulsing. And then, of course, the symptoms also are determined by metastatic sites and also constitutional symptoms. If it's lymphoma, they'll have what we call B symptoms, which are fever, night sweats, and weight loss. Or you can have paraneoplastic manifestations, such as myasthenia gravis, symptoms like, or good syndromes, which I'll discuss later, or again, They can also present with the syndrome of inappropriate ADH with hyponatremia. So mediastinal mass evaluation, of course, we need the real evaluation really to narrow down differential diagnosis and guide management. So you need to analyze the key parameters, which would be your clinical context, especially your age and sex. Obviously, a young male with mediastinal mass will point you toward testicular cancer, teratomas, lymphomas. And obviously, the symptom normally really would follow up with underlying what's really the etiology. And of course, pre-existing disease probably also can lead you to the diagnosis, whether the patient connected to disease or being diagnosed myasthenia gravis will always will give you some kind of hint. Imaging characteristics, especially compartmental location, size, and shape. And most of the time, sometimes you pick up on the X-ray that the mediastinum is wider than usual. And then, of course, that probably will guide you. The type of disease process, of course, that will be an evolution of the clinical radiological features as symptom prior to imaging. Sorry. And then mediastinum mass, of course, imaging would be your imaging modality of choice in most, will be defining your CT scan. It's really, I think, number one choice of the imaging. Chest X-ray is really fallen out. And if the CT scan, what it does is actually defines the locations, which your compartment, the size, the shape, and density, boundaries, effect on adjacent fractures. Calcification does not guarantee that the condition is benign, because you have cancers like teratomas, they'll have a lot of calcification, but they can be malignant. MRI is useful in selected cases. It's not number one choice of imaging. It really can tell you more about the superior tissue structures and also can assess a vascular or chest wall invasion, intraspinal extension. And then PET scan useful for suspected lymphoma, but the problem with the PET scan is just, I always call it the Christmas tree, where it just lights up. And sometimes it's very difficult to really be 100% sure or what diagnosis could it be. It just helps me to make a lot of lists of differential diagnoses. Other modalities will be, of course, your TE, what we call transospocal echo, and that'll be very good in diagnosing your aortic aneurysms, or technician scans for thyroid, if they're retrosternal thyroids, or endobronchial or spogal ultrasound. This is really in the setting of patient with mediastinal with suspect to be adenopathy, and you can do what you call endobronchial ultrasound plus biopsy or sampling of the tissues, or in that case, you can use spogal depending on the window of the lymph nodes or the where is the lymph node located. And then for young children, you need to consider sclerotal ultrasound because, as I said, the risk of malignancy are high in testicular tumors. And of course, other dotted CT scans also one of the modalities that can be used. Another laboratory test for anterior mediastinal mass, tumor markers are very important. And one of them is really as anti-acetylcholine receptor antibodies. So now the problem with anti-acetylcholine receptors it has really three roles. One, it can block the receptors, or it can actually modulate it, or can also give you a different kind of effect. And the problem is that, so the symptom can be either the disease will improve or get worse, or stay the same. So it's really, so you need to interpret it with caution. That's not, the presence does not mean that equal to the myasthenia gravis. And one of the second markers that you could do is alpha-fetoproteins, which is normally, I think, tend to be linked with the kidney, with the liver hepatocellular carcinoma. However, in this setting, it's really also elevated in the malignant germ cells tumor, specifically 60 to 80% of non-seminomatous tumors, where it's normally elevated. LDH, unfortunately, is not specific, can be seen in a lot of conditions from hemolysis, bacteria infection, lymphomas, and the list is endless. So it's really not specific in this case. But if it's elevated, that also really indicates more male kind of tumor, non-seminomatous, these embryoma tumors. Beta ECG is not only really indicated for males, there's a role of beta ECG in males, not female only, in males. In females, more pregnancy. In males can be, it means it's a marker for cancer in seminomas, 10%, and non-seminomatous in 30 to 50% germ cell tumors. Other tests in selected case will be a thyroid function test and then, of course, thyroid ultrasound. Now, how do you classify mediastinal tumors? That we classify into 3 categories. Those arise from the anterior compartment, middle compartment, and posterior compartment. In anterior compartment, there are 5. There are really, I think, 6 of them. One is the thymoma, thyroid, lymphoma, germ cell tumors, and metastasis. But of course, you have miscellaneous. Middle would be a lymphoma, metastasis, non-malignant adenopathy, cyst, and vascular lesions. And posterior would be a neurogenic tumors and esophageal lesions. And of course, miscellaneous. So this is really a up-to-date diagnosis of mediastinal tumors. Now, if you zoom in into up-to details, you look at the anterior compartment, it will be a thymus. Now, presence of thymus enlargement can tell you about 4 things. 1 could be a thymoma. 2 could be a thymus cyst. 3 can be a thymic hyperplasia. 4, it will be thymic carcinoma. So you need to interpret the questions, and you kind of need to have probably more investigation. Lymphomas, of course, we see that are common, and germ cell tumors will be quite few of them. Can present will be those that are teratoma, ademoid, or dermoid cyst, seminomas, or non-seminomas. And then yolk sac tumors and embryonal carcinomas and choriocarcinomas. Choriocarcinoma, again, we've seen that more in female with during pregnancies as compared to males, but that, again, it does exist in male. The intrathoracic thyroid will be substernal goiter and ectopic thyroid tissue in the mediastinum. Of course, miscellaneous will be a parathyroid adenoma, hemangiomas, lipomas, liposarcomas, fibromas, and fibrosarcomas, and pyramid of Morgandi hernia. In the middle compartment, of course, will be a bronchogenic cyst that we see quite a lot in pulmonology, pericardial cyst also, and lymphadenopathy such as lymphoma, sarcoid, and metastatic lung cancers. And then, of course, not forgetting enteric cyst, or which is related to intestinal, and then esophageal tumors, vascular masses, and enlargement. Posterior compartment is quite very straightforward, which will be a neurogenic tumor such as neurofibroma and neurolema, and then neurosarcoma, gangliomas, and neuroblastomas, and then of course covered chemodepitomas. Okay, and then pheochromocytoma is one that can mimic, and they can present with labial blood pressures. Meningocele and thoracic spine lesions such as Porter disease in terms of the TB. So how do you manage mediastinal tumors? That will be, of course, you observe, if likely benign, especially when they're not painful, stable, asymptomatic. Those will be cysts, do nothing. Biopsy is always indicated, such as percutaneous or bronchoscopic or surgical, depends on what's really your high index suspicions. If you suspect lymphoma, biopsy is really a key with the B symptoms. Larger unresectable tumors, also biopsy can help, and high surgical risk or complex surgery. Resected without biopsy, those would be a benign cyst, because once you biopsy, they're going to really seat your mediastinum with quite a lot of those fluid. And resectable tumors, also incomplete thymoma, you must avoid biopsy, and the reason is because they can cause seeding to the mediastinum. So let's look at anterior mediastinum. I think for those who always been with Prof. Richard at West University, he'll be asking you about differential diagnosis of mediastinal tumors. And the giveaway is always, we say, the 4 T's, which would be a thymoma, cerebral lymphoma, and then teratoma, and thoracic thyroid. But also a thoracic aneurysm is the 5th one. Miscellaneous will be a parathyroid tumor, mesenchymal neoplasm, and Morgandini's hernias. Okay, but those I really haven't seen one before. Thymoma, let's just have a look. My previous discussion discussed thymoma, but let's have a look. Thymoma would be really, you pick them on the X-ray or CT, tend to be round, well circumscribed, homogeneous mass, typical anterior to the aortic root. And if you look at my mouse, it's there. That's your thymomic mass. Half of the anterior mediastinal tumor in adults, usually on a 4 to 3 decay, 30 to 50% symptomatic, local or constitutional, and then parathymic, such as parathymic or what we call paraneoplastic syndrome from thymus would be a myasthenia gravis, most common, and good syndrome, which I'll discuss later, and also PRS cell aplasia, which is quite very common in the government sector that we see quite a lot of them. And probably we don't see much of it. And of course, they can also present connective tissue disease. So rheumatologists, they can present rheumatologists because they have arthritis, features of lupus, or scleroderma. Histological classification, which is World Health Organization. I'm not going to go into detail with that. And staging classification, they use the TNM, modified Sanocare. Thymoma, of course, diagnosed, CT-guided, core, needle, or surgical resection. Staging and management, two-thirds encapsulated, surgical resection, 5-year survival 75%, and 1/3 invasive with surgical resection, adjuvant chemo and radiation. 5-year survival in 50% of cases. Metastatic disease is very rare, but chemo with cisplatin-based therapy. Thymectomy yield improvement in myasthenia gravis in most, effective not improvement in patients with the refractory myasthenia gravis. 1 to 10 years for effect, and inconsistent benefit for good syndrome, such as PRS cell aplasia. Surveillance, of course, we do prolonged follow-up, 10 years indicated, slow-growing tumor. What's good syndromes? Good syndrome is really hypogammaglobulinemia, and they tend to present with, and also they also tend to present pure white cell aplasia, means they have mostly neutropenia and low white cells really. And less than 5% of patients with thymoma, most commonly in older adult females. 10% of patients with acquired hypogammaglobulinemia have associated thymoma. In histological spin, they tend to on biopsy, they tend to have present with a spindle cell type on biopsy of thymoma. Clinical, they tend to present recurring infections, diarrhea, and lymphadenopathy. So thymectomy does not reliably lead to the return of normal immunoglobulin levels. They might be a candidate for polygam for lives. And that tells you again, once you see a patient with underlying low globulins, you need to consider CT chest or chest X-ray to just screen for thymic mass. Other thymic tumors, of course, will be thymic carcinomas, adults in 5th and 6th decades, symptomatic, large, aggressive tumors, tend to be resectable when feasible. So that's again, you could see that the cancer there. You could see the cancer there up to here. It's really your mediastinum, and these are patients that will present with superior mediastinal syndrome. Thymic neuroendocrine tumors, such as carcinoid, also are very common, well known, and then they tend to present ectopic hormones production in 1/3 of the cases, and the features of Cushing or carcinoid tumors, and muscle syndrome inappropriate ADH. And that's for me, it's again, most of these patients might present to physicians because of the low sodium, or they can present also to endocrinologists. So again, you need to always think about thymus. And then you can also have a thymic lymphoma, thymic cyst, and thymic lipoma. Now, mediastinal lymphomas, let's have a look at quick event. Lymphomas, of course, in the fifth, is the fifth most common cancer in the US, usually involved in mediastinum as part of widespread disease. The primary mediastinum, 5 to 10% of lymphomas, Hodgkin especially. Nodular sclerosis type is more than the non-Hodgkin. Usually young adults with the B symptoms. The B symptoms, of course, and local compression with superior mediastinum syndrome. Chest X-ray or CT is normally an investigation choice. You will see lobulated mass or bulky adenopathy in anterior mediastinum, with most people with mistaking it for sarcoidosis or TB. So you need to have a tissue to make an accurate diagnosis. So diagnose, of course, CT-guided core needles or EBUS, endobronchial ultrasound guided bronchoscopy or surgical biopsy. Imaging, that's how lymphoma look in the lung. You could see extensive matted glands there, around the aorta, your pulmonary arteries, of course, and through mediastinum is quite full. And if you look at the X-ray, there's widening of mediastinum with the obliteration of cardiopulmonary window. Let's quickly have a look at superior vena cava syndromes. I think when I was doing my training time in Joburg, we tend to see quite common of it. But I think in private, I think we saw 1 or 2 cases. So superior vena cava syndrome, of course, is where you have obstruction of blood flow through the superior vena cava as a result of direct invasion of tumor into the superior vena cava, which is normally a malignant case, or by external compression with a lymph node or expansion of the local expansion of the tumor. So it's pathogenic process involved the right lungs can also lead to that, or because the superior vena cava is more toward right than left. Lymph nodes and other mediastinal structure leading to stagnation of flow and thrombosis. So sometimes anticoagulation will be beneficial. Symptoms and signs of thoracic central venous obstruction can include swelling, chest pain, respiratory symptom, or neurogenic manifestation because of congestion. The treatments, glucocorticoids, if we see most of our training at academic, most of these patients are given glucocorticoids. But glucocorticoids actually indicated in 2 settings. One is when the patient got a severe airway obstruction, or second, if they suspected that the patient might have lymphoma, which is normal lymphoma because that's respond to steroid or thymoma. So superior vena cava obstructions, there's about 4 classifications, and which is type 1, 2, 3, and 4. In type 1, it's classified A to D, where both your bronchocephalic vein and superior vena cava are patent, but one of the internal jugular vein or superior vena cava is obstructed. If patency of all thoracic veins cannot be determined, this type of the thoracic obstruction can be classified as type A, 1A, or type 1B. Type 1A, where you have unilateral internal jugular vein or superior vena cava obstruction with patent, equilateral bronchocephalic vein. Patents of all other thoracic central venous system is not known. In type 3, where you have unilateral internal jugular vein or superior vena cava obstruction with patent, if it's lateral bronchocephalic vein. And then type C, where you have unilateral IJV or SVV obstruction with non-patents of the contralateral. And type D, where you have bilateral actual obstruction of both. In type 2, of course, any form of the TCV that causes unilateral bronchocephalic obstruction if it's lateral. And again, you have A and B. And of course, type 4, where you have a superior vena cava obstruction that will prevent or impede direct thoracic venous flow to the right atrium with any constellation of bronchocephalic vein, internal jugular vein, or superior vena cava. So primary mediastinal lymphomas, those would be management would be a Hodgkin, where radiation and chemo, they tend to respond quite very well. And then non-Hodgkin would be radiation and chemo. Prognosis is better for Hodgkin, 5-year survival 75%, than non-Hodgkin, where it is 5-year survival 50 to 60%. Let's look at the mediastinal germ cell tumors. They tend to be benign and malignant tumors, usually anterior mediastinum. 5% of the GCT arise in extragonadal location, easy mediastinum. In adult, 15% of anterior mediastinal tumors, most commonly a young male but however, you must always evaluate the testicles. There's a risk in Klinefelter syndrome, which is 47XXY syndrome. 1/3 of men with mediastinal GCT have Klinefelter syndromes. Classification, of course, will be teratomas in 70%, seminomas, and non-semimatous tumors. Diagnosis, needle or surgical biopsy, and resection. Teratomas, which is always very interesting tumors. I think I diagnosed one in female, but mostly was one of the ovarian teratoma, and we actually found that there was a teeth in it. So teratoma, 67% of mediastinal GCT tumors, most benign, occasional malignant degenerations, such as teratocarcinomas. Varying amounts of tissue driven from second of the third primitive germ layers, ectoderm, mesoderm, or endoderm. Children and young adults likely and commonly asymptomatic. Expectoration of air, sebaceous debris, uncommon. Tumors, of course, you get a chest or CT. You see them as well circumscribed, round or lobulated heterogeneous mass, may contain fat. Contain fat, and then also calcifications. You can see the calcification or cystic, 89% changes. And then management excision through the median stenostomy or posterolateral tracheostomy. Trachoscopic resection is also possible. Mediastinal GCT, you've got seminomas and non-seminomatous. So malignant tumors in young men, 90% symptomatic, local and constitutional. Seminomas, of course, you have the most common malignant GCT, serum AFP is normal, but however, there's increase in beta SCG in 10 to 35%. Chest or CT, so you see larger lobulated, homogeneous, one circumscribed mass. Management, radiation, or chemotherapy. Majority have metastatic disease during diagnosis and 80% cure rate. That's all I say. Testicular cancer is one of the very favorite cancer for males. And then prognosis, 5-year survival is about 80 to 90%. Non-seminomas would be a serum AP of 80% and increase in beta HCG 30%. So I think the trick is that once you always have to do your 3 markers, and if AFP is positive, tell you non-seminomatous tumors, and if AP is negative, then you know it's seminomas. Chest X-ray, of course, will be larger, irregular, heterogeneous mass, invasive mets with the lymph nodes and infusions. Management, assistive platinum-based combination chemo, resection is also possible, but however, the issue of risk of having residual tumor. Prognosis 5-year survival rates about 40 to 50%. And then the intrathoracic thyroid that we encounter daily in our lives, we see quite a lot, especially with the physician-based practices, and that you always pick them up on that X-ray in the casualty where you find that actually there's widening of superior mediastinum. And I always say that you would not put your hand below it. When you look at this sternal notch, you find that it's quite bulky. You cannot put your hand between the thyroid and the sternal. So most of these patients having thyroid goiter into mediastinum, most benign 10 to 15% contain cancer or lymphoma, often middle-aged women. I don't know why, but the symptomatics, compression trachea, esophageal, nerves, and blood vessel. CT scan, you see a superior mediastinal discrete lobulated mass, contagious with the thyroid, heterogeneous fascination with tracheal narrowing or deviation. Management, surgical excision, usually cervical approach. But you might need a multidisciplinary where you have a cardiothoracic doctor and your surgeons combination. Other mediastinal masses, that will be a metastatic disease such as and also your parathyroid cyst or carcinomas or adenomas. And then, of course, mesenchymal tumors such as lymphoangiomas, lipomas, leiomyoma that you find in the lung, and of course, the hernia, sarcastic radical features. Let's look at the hernia. They tend to be more retrosternal, usually right sides, most of the time. And in adults, usually no symptoms. Surgical repair, generally recommended. Middle mediastinum. There's really nothing much to talk about it. It's really, we know that contain your heart, large blood vessels, lymph nodes, trachea, and main bronchi. So middle mediastinal masses normally tend to be malignant lymphoadenopathy because of lymphomas or could be sarcoids or lymphomas metastatic such lung cancers, where you have secondary malignancy. Non-malignant lymphoadenopathy will be a sarcoidosis, drugs and other infections, silicosis, congested heart failure. And the cyst will be bronchogenic cyst, pericardial, and vascular lesion. Other lymphomatosis, hernias, and lymphadenopathy. And I think yesterday we have a patient that presented to Dr. Darren Joseph, and we suspect that the patient actually might have lymphomatosis with a restricted lung disease, but we still yet to confirm. Bronchogenic cyst, this will be a Fogat malformation, lined with ciliated respiratory epithelia, tends to be asymptomatic in 60% of cases. CT scan show uniocular, homogeneous water attenuations, and then always near larger airways, subcarinal or right paratracheal, observed, aspirate, or resect. And just to show you, there it is. Pericardial cyst, we see that quite a lot. It's again, it's uniocular, water attenuated, thin wall with right CPA and no intervention. Where is it again? Let me show you. This is okay, there. That's a pericardial cyst next to pericardium. And then on the X-ray, you can see there. So it's not, most of the time, don't put needle in. If in casualty, you're not missing any. Just CT scan, refer to a specialist center. Vascular lesions, that will be your vascular lesion example will be aneurysm. And if you look at your X-ray, I wish we can do a quiz about it. You can see there an opacity on the left side there. But again, you always have to go through the motion or differential diagnosis. Okay, that will be your aneurysm and fistula, and of course, mediastinal mass, you just have to go through the differential diagnosis. And may radiologically also resemble bronchogenic carcinomas, a special upper lobe. Diagnose, you need contrast, CT, MRI, or angiography. Mediastinal lymphomatosis, I thought maybe because yesterday we saw one, I thought maybe we could just touch on it briefly. They tend to have abnormal adipose tissue accumulation in mediastinum next to the pericardium. Clinical context, obesity, and chronic steroid. Most of these patients obviously have some degree of obesity, class 1 or 2. And then they might also, you always need to make sure they might be cushingoid with ectopic ACTH. So you must always check for ACTH. Chase or CT scan, you get mediastinum widening, smooth boundaries, fat attenuation, and sometimes mass effect. Mediastinal lymphoangiomas will be congenital or acquired, usually in the neck, can be mediastinal, benign but can slowly enlarge and infiltrate. CT scan can be solitary or multilobulated. Again, you could see on the X-ray there, those multilobulations there. And then variable size, well circumscribed. Again, they tend to be water attenuated on CT, multiseptated masses, management complete resection if feasible. Posterior mediastinum. So this is always very interesting. I think I haven't seen much of it because most of the neurologists or neurosurgeons, they tend to present with neurogenic neoplasm in 60%. Asperger lesions where you have hiatus hernia, I think that's mostly what we see. Neoplasm, varicose, and extra. Miscellaneous will be, of course, your descending aortic aneurysm, and then of course your hernia and extramedullary hematopoiesis, lateral meningocele. Neurogenic tumors arise from the peripheral autonomic or paraganglionic system, and they tend to be benign in 70 to 80%, asymptomatic in half or 2/3 of cases, often first detected on chest X-ray or CT, 90% in paravertebral gutters, 10% extend through the neuroforamen intraspinal canal, what we call dumbbell. MRI is more sensitive than CT, delineating intraspinal extension. Multiple lesions suggest neurofibromatosis type 1. Management, surgical resection when feasible. Neurogenic tumor, of course, by peripheral nerve tumors. Most common type of neurogenic tumors, of course, will be benign Sinomas tumors. Okay, I always struggle to pronounce that from my 90% of other neurogenic tumors in third or fourth decade of life arise from intercostal nerve and commonly asymptomatic round or lobulated masses with bone erosions. Malignant peripheral nerve neoplasm, of course, would be a neuroblastoma, ganglion neuroblastomas. They tend to be painful, heterozygous masses with local invasions, and always look for neurofibromatosis. Benign peripheral nerve tumors would be, of course, sinomas and neurofibromas. And other mediastinal masses will be extramedullary hematopoiesis, that present with extramedullary hematopoiesis. Those will be hemoglobinopathies, chronic anemia, myeloproliferative disease, and occult paraneoplastic masses or rib expansion. Lateral meningocele, they can give you paraneoplastic cystic lesion and neurofibromatosis type 1. So in summary, I think we just see, diagnostic approach, mediastinal mass in both clinical context, analyze imaging features, and tempo of disease process. Most common mediastinal lesions are thymomas, lymphomas, neurogenic neoplasm, and metastatic disease. Always, if in doubt, ask for opinion from a specialist pulmonologist, physicians, cardiothoracic surgeons, or endocrinologists. And that's the reference. Thank you.
Thank you very much. I think it's a good topic. I think it's one of those topics that whether you're a medical student or doesn't matter what kind of clinical doctor you are, it's going to follow you around and you have to know it. You'll find it at some point. I don't know if there's anybody who's got any questions or anything. Maybe somebody online. I think it's one of those conditions we start with like a chest x-ray because you need to know how to read your chest x-ray. And I mean, it's happened to me more than once that I've had a patient come consult me for non-specific symptoms like just fatigue. And then, just by doing a plain chest x-ray, you end up finding a mediastinal mass. So
I think most really the casual office tend to be the first point of entry, especially because most of the patients will come with something completely differently.
Yeah.
And incidentally.
Specific findings. Sometimes.
Yeah. But I think it's very important to really have differential diagnosis. And the idea is that once it's on podcast, when always you encounter one, and you'll be surprised that you'll find something. Yeah. That's something different. Any question out there, guys?
Bianca.
Good morning, it's Bianca.
We can see you.
Can
How are
you
you?
see me? I just wanted
We're
to comment.
imagining.
You think that this doesn't happen to you, and just yesterday I had a patient who just came in with feelings of depression and feeling tired. Her GP sent her in for an ECG, and I found one of your mediastinal tumors on my patient just yesterday. And then you don't see it again for months, and then you see 3 or 4 again.
Yeah.
Thank you for the lecture, Dr. Taban. It's a lot of things to catch up on and read up on again. Thank you very much.
Yeah, I think you're right. You just need a high index of suspicions. I think if you work in casualty, you always say that if you sit there in casualty, when you say next, you have a mediastinal mass, next foot ulcer, next appendix. So everything comes your way. That's why you have to have ongoing. I think for me, people should not use an ED emergency to work in emergency just as a way of getting, because they want to go somewhere. I think if you're there, you must actually enjoy it because the pathology is quite massive. You can actually learn a lot. And most of these things actually follow you whenever you become later in your career. So you really have to kind of have passion in what you're doing if you're in ED. ED should not just be a kind of, by the way, because I have no job, I'm going to be in ED. No, please don't do that. You must love when you are there, make the best out of it.
I was just looking, looking at the chest x-ray. I mean, it's easy to diagnose a obvious pneumonia, obviously a spot in the lung. But those mediastinal tumors, I mean, it's so subtle. If you just glance at it, you're going to miss it. Yeah. So at most, you probably, in most of the cases, you're going to get something doesn't look right, something, and obviously it's important to now interpret the chest x-ray and mediastinum, just anterior and lateral. And if there's any suspicion, get a radiology report.
Yes.
And then consult either physician or a cardiothoracic surgeon. And that patient from yesterday that you admitted that had the brain tumor from childhood, now stage 4 cancers, and has got mediastinal mass.
Yeah, he's obviously got a metastatic because the primary seems to be a brain tumor. But I think it just highlights the importance of the chest X-ray, and like it should always be part of your kind of basic assessment. You can't, as I say, be symptoms or plain very non-specific like fatigue or I just don't have energy or whatever. Your chest X-ray still needs to be part of that investigation because, for example, you may be doing bloods only and you would totally miss.
I think most of us do a chest X-ray to look for obvious cardiac enlargement and pneumonia. But I mean, there's so many. There's so many tutorials on as a revision to how to interpret the mediastinum on a PA and a lateral. And I think we need to sharpen those skills and keep it sharp because these things are going to be so sudden. You have one chance. You send this patient home with a course of antibiotics because you don't know what's going on, and this patient presents a year later.
Yeah.
And you've missed the opportunity.
But the good news is that we actually lined up one of the greatest professor in South Africa, Professor Feldman, who is a pulmonologist and renowned in real pulmonary medicine, not only in South Africa, but internationally. So he will give us a presentation on chest X-ray, how to interpret, what to look for, just ABC of X-ray. That will probably just watch us for detail. We'll share the link. Soon Leanne will share the link once we confirm the date. It's probably going to be Monday. It's going to be not on this time, but we'll tell you. We encourage that all the people must attend because he's really quite renowned on radiology. I learned it from him. He has taught me at Wits University, and I'm always very in awe with him. He's quite a very great professor. So we'll bring him on lines to kind of teach us X-ray. And that's what we need to do. It's really going back to basics and just like kind of equalize the knowledge, because I think for me, knowledge is key. Yes, maybe the presentation is too much, but I think, you know what, when you get stuck now, I know that going forward, the next few months, people are going to start diagnosing mediastinal masses because now the idea is being planted. Now you know what you're looking for. Remember, we diagnose what we know. So now the fact that the idea is to trigger your mind to think differently. When you're in casualty, think about mediastinal masses and look at your X-ray, always look at your mediastinal. If there's problem, what's up the X-ray, we always can give you a comment about that.
I must just say, obviously we need to be confident and skilled at interpreting chest X-rays, but also we rely on the radiologist as our backup. But I see so many doctors not writing any history or very basic history for the radiologist, for the X-ray. And so now you expect the radiologist to go and look for a needle in a haystack. So it's so important when you request an X-ray to give an appropriate and detailed history to the radiologist so he actually knows what to look for. And then you'll get a more appropriate report. Because even radiologists can miss something if they have no idea what they're looking for.
Yeah, question like, do you have any questions? Any other questions, guys? All right, if that's the case, then we can actually say thank you guys for attending. We appreciate it. And see you guys next week.